All right, why don't we go ahead and get started for the afternoon session, plenary session. Knock, knock. Who's there? Thank you. Somebody did hear me. All right, welcome everyone. Welcome back to our annual meeting and our next session, which is a plenary session on eliminating hepatitis C in the US. So interestingly, Boatum and I were emailing last week on who was going to say what, just so we could coordinate our talking points. And I realized after Boatum described what she was going to say, it's like, well, what am I going to say, right? You've already described all the most important pieces. But quite literally, as we finished that exchange, I was reading through my email and noticed that there was an article in Forbes magazine of all places on elimination of hepatitis C in Egypt. And I know we are loath in the US to learn examples from what happens in other countries, especially when other countries are in the developing world. But WHO did an analysis and a review of the success in Egypt and identified 6 key factors that contributed to Egypt essentially eliminating hepatitis C. And for the quick background on Egypt and hepatitis C is they had essentially a population outbreak of hepatitis C due to contaminated needles. And a significant portion of the population, something like maybe 20% of the population were infected with hepatitis C. And so they embarked on an effort to eliminate the hepatitis C by treating something like 1.something million people, 1.25, I think, million people. And this is what the WHO evaluation showed as the kind of the key contributing factors or environmental factors or contextual factors that contributed to that success. One was political will. And actually, I would say that there are 6, 1, 2, 3, 4, 5, and 6 could be political will because it was so important to have the buy-in of not only the Ministry of Health and the health infrastructure, but the legislature and the president of the country. The number 2 was updating national health strategies and national priorities around hepatitis C. So basically making this a national priority to end hepatitis C. They reviewed and updated relevant HCV legislation and regulations. So looking at the policies, the regulations that were facilitative that in achieving their elimination goal. Money, so funding. And linked to funding was the cost of drugs and reducing the cost of drugs. And then the final component was the monitoring and evaluation and real-time feedback and action. And as I look at all of these 6 factors and think about kind of where we are in the US, we have touched on each of those things in various ways and various shapes. But for us to really be successful, we really need to lean into all of these to be successful. And so I'm really looking forward to this session because the fact that we're having this conversation is because the President of the United States has made eliminating hepatitis C a priority, and we need to get other folks on board with that. So with that, I'm going to stop there. I know we have a short video that we're going to show from our colleagues at ViiV, but then I'm going to hand it over to Boatuma to introduce our panel and look forward to really a great introduction and conversation around the National Hepatitis C Elimination Plan. Thank you.
The way we see it, the impossible
is not impossible.
The impossible is simply what hasn't been achieved yet.
So we pursue it.
We chase it down.
We tackle it for answers.
We surround it for a way in. This is how every once impossible breakthrough has ever been created.
a revolutionary approach to cancer therapy.
A path to a cure for HIV.
A cure for hepatitis C.
A better, healthier world for every person to live in.
None of this is impossible now because of the people you work with.
The communities we stand with.
And the partners we push forward with.
Together, we've created what's possible through science,
Grit.
compassion,
And courage.
and we will do it again, no matter what.
No matter the stakes.
No matter who says we can't.
When faced with the impossible, we don't falter.
We band together and we prove it wrong.
The impossible.
Is not impossible.
It's what's next.
C'est notre futur.
우리가 다음에 해야 할 일입니다.
가담을 바지. Ano ang susunod?
Es lo que sigue.
呢個就係我哋嘅下一步。
It's what's next.
All right, good afternoon. So y'all don't know me. Let's try that again. Good afternoon. Awesome, awesome. Especially, we've been waiting decades for this, right? We've been waiting decades to be able to say that we are on the brink of having a national hepatitis elimination plan before us. And so for that, I need us to be very excited, a little scared, and that's okay too, but excited, especially about what you're about to hear on this panel today. So with that, I will hurry up and get started because I know you don't want to hear from me, you want to hear from them. So good afternoon on behalf of Isabel Lechuga, my co-coordinator on this panel, and myself. We're excited to finally be able to get to this third and final plenary of the day after a day of absolutely phenomenal plenaries earlier. First, we want to do some grounding. So before we get there, I should introduce myself, right? I'm Bwatuma Ntiri Reed. I'm the Senior Director for Syndemic Approaches at NASTAD. And prior to joining NASTAD, I worked for a number of years within the health department at Maryland on viral hepatitis and served people who were living with viral hepatitis and HIV. So just to kind of get us to a place of understanding where we're at with hepatitis C today, and of course, you'll hear more in just a moment. In the United States, an estimated 2.4 million people are living with hepatitis C. For those of us who work in viral hepatitis every day, those of you who are doing syndemic work, you hear that number all of the time. Perfectly, CDC beats it into us because we need to hear it. We need to feel it, we need to think it, and we also need to recognize that it's an estimate. So it's possible there are even more people who are living with hepatitis C. And while the number of hepatitis C related deaths in our nation had fallen, we've since seen an increase. And in 2020 alone, nearly 15,000 people lost their lives to viral hepatitis, a condition, a chronic condition that a lot of people still don't even know exists, or if they know the name, they don't actually know what it is. But we're gonna work on that, of course. Hepatitis C is undoubtedly one of our nation's most significant public health crises, and it's also the most preventable and treatable, and as we all know, it's curable. Therapeutic innovation has taken HCV, or hepatitis C, from a chronic condition with treatment options that impose devastating effects. Some of you in this room might have dealt with those effects. Some of you have worked with individuals who dealt with them or have family members who dealt with them. But now we're in a place where just in a matter of weeks, you can be cured. Despite this, less than half of people living with chronic hepatitis C know their status and far fewer have been treated. So enter in Drs. Collins and Dr. Fleurence. In 2022, a bold and audacious initiative of the White House was proposed. It was led and is continuing to be led by Dr. Collins, former acting senior advisor, to President Joseph R. Biden Jr. and former director of the NIH, and his senior advisor, Dr. Rachael Fleurence. And they will continue to lead on this work at the request of the White House. The program aims to significantly expand screening, testing, treatment, and prevention of hepatitis C in the US. And as President Biden stated just last week about the plan in his proclamation on National Hepatitis Testing Day, if you haven't seen it, I promise you your hepatitis staff have, and they have it handy. It is within our power to save tens of thousands of lives and billions of dollars in healthcare costs. And if implemented as designed, in 5 years, we'll see people living with hepatitis C cured, as well as the number of people who are diagnosed with hepatitis C infection increased almost 93% aware of their status. Today, we'll discuss the plan, our nation's first hepatitis C elimination plan, and why the time is now. For today's discussion, I have the honor of engaging the panelists to my left, a panel of prominent national public health leaders. First, we have Dr. Francis Collins of the National Institutes of Health, Dr. Rachael L. Fleurence of the National Institutes of Health, Dr. Sue Lin, Acting Office Director, Office of Quality Improvement, Health Resources Services Administration, Dr. Jim Gandotra, Chief Medical Officer, Substance Abuse and Mental Health Services Administration, Dr. Timothy Stenzel, who will be joining us virtually, of the Director of the Office of In Vitro Diagnostics, Office of Product Evaluation and Quality, Center for Devices and Radiological Health at the U.S. Food and Drug Administration. And last but certainly not least, Dr. Carolyn Wester, Director of the Division of Viral Hepatitis at the National Center for HIV, Viral Hepatitis, STD, and TB Prevention, Centers for Disease Control and Prevention. So to quickly review the agenda for today's panel, we'll begin with remarks from Dr. Collins and Dr. Fleurence. We'll then transition to a moderated panel discussion. And so that's where you all come in. While we do have questions that we're very excited to pose to our panelists today, we also very much want to hear from you. Over the course of the last few days, we've heard a number of challenges that you all are coming up against, as well as successes that you're having in your jurisdictions related to hepatitis or the integrated approaches you're taking to address hepatitis. Today is an opportune time. I don't know when we're going to get all of these folks back up here together to be able to address some of those challenges that you might be confronting. So now is that moment. So as you're listening to today's discussion, please be sure to take notes, to mark down your questions, and to present them, as there's no time like the moment, right? The theme of this panel is the time is now. So with that, I am going to pass things off to Dr. Collins and Dr. Fleurence.
Thank you very much, Botama, and good afternoon to everybody. I'm delighted to have the chance to speak to you all because NASTAD has been a fantastic partner in this effort to mount what we believe is a historic opportunity to eliminate hepatitis C in the United States. If I could get my slides up, which I hope are somehow queued up there and ready to go, looking in the back corner and hoping to see some sort of nod. Oh, yes. Okay, it's there, it's not here. Is there any way you can feed it to the monitor? Or shall I just look to the side? Seems I'll be looking to the side. All right. So I wanted to begin by saying that this is something that is compelling as a public health opportunity, but it's about real people. And I think all of you in this room know that better than most people on the planet because you have been doing everything you can to help find, test, and now cure hepatitis C. And as I think about this, I often think about the person who's on my mind for hepatitis C, who brought it to my attention initially. That's my now deceased brother-in-law, Rick, who died about 10 years ago of hepatitis C before the cure was available. And it was certainly a very difficult experience watching what happened. Oh, okay, thank you. So I'm going to start with some facts and figures, and then I'm going to turn it over to Rachael Fleurence, who will walk you through the points that are included in the President's initiative. So to begin with, slides from CDC, who have been fantastic partners in all of this. We are not in a good place, as you know extremely well, in terms of acute hepatitis C cases going up 400% during 2010 to 2020, and driven, of course, by the opioid crisis, particularly in people who inject drugs. If you look at the epidemiology of where the hepatitis C infections are on the right side of this slide, there's sort of two bumps in this. There is the younger group, the millennials. Much of that is, of course, reflective of intravenous drug use, but there's a bump also, thank you, this is great, for the baby boomers, many of whom presumably were infected by blood transfusions before we knew how to screen for Hep C, which is about 1993. And again, you heard the numbers, estimated 2.4 million people living with hepatitis C, about 40% of them unaware of their infection. And I'm also very suspicious that that might be an underestimate, since we don't have very good ascertainment in many populations. It's curable. And it's amazing how many people don't know that, including lots of physicians. A lot of people are still thinking, oh, hepatitis C. I remember when you tried to cure that, it was a horrible protocol where people were sick, like they had the worst flu of their life for 6 months, and then it didn't work. Now we have a cure, 1 pill a day for 8 to 12 weeks, 95 to 98% cure rate, essentially very little, if any, side effects. How often do we get to have that kind of outcome? This is one of the greatest triumphs of the last 20 years of medical research. And yet the benefits are not reaching an awful lot of people who need them. And the reasons for that, diagrammed here in this particular example of a runner encountering a lot of obstacles: lack of awareness. The diagnostics are clunky, as you all well know. The current approach requiring antibody testing at some centralized lab, then come back for RNA testing, wait again for the result of that, then come back, oftentimes then sent to a specialist. This is not necessary for a very straightforward condition where I think a nurse practitioner, a physician assistant, maybe a pharmacist can quite nicely diagnose and cure hepatitis C. And yet all these barriers are up there. And you all know why that is, because it's costly. And therefore, Medicaid programs, the uninsured, people in prisons, people on the Native American reservation are not getting the access. These barriers are up there in the way. And primary care docs haven't really jumped in because, again, most of them are not familiar with this and maybe uneasy about the populations that they would need to get comfortable reaching out to people who inject drugs, justice-involved populations, the uninsured. It can be done. You still encounter people saying, well, you know, it's just too hard. This is the Veterans Administration success story. They had separate funding from the Congress to do this. And over the course of 7 years, you can see what they achieved in terms of treatments with DAAs and what was the success rate in terms of sustained virological response in the neighborhood of 90 to 95%. And they reached the vast majority of veterans. And that is not an easy task either. And they managed to do it. And we can learn from that experience and already have. In the States, we've been particularly paying attention to the Louisiana pilot, which was mounted back in 2019, just in time to have COVID come along and make it really hard to do. And yet they pressed forward for both Medicaid and for the federal prison system, and came up with strategies that did in fact identify and offer a cure, which was then carried forward. So the cascade of care here is pretty good in terms of who achieved SVR. And again, that's another thing we've learned a lot from by studying this and talking to Rebecca Gee, who was the Secretary of Health for the state of Louisiana at the time that this was put together. And interestingly, for where we are right now, needing congressional support for a national initiative, a major supporter of this in Louisiana was Senator Bill Cassidy, who is a liver doctor and who currently is the ranking member of the Senate Help Committee, and a very important place to be able to try to nurture this initiative forward. Because if Congress doesn't decide they love this, the administration's support won't get us what we need. So maybe I should say right now, the big push right now in the next coming months, and hopefully not too many months, is to convince the Congress that this is something just too compelling and you just can't pass it up. You can't look at this and walk away. Well, for some reason, the clicker doesn't seem to be clicking. I don't know if we lost a battery or something. There we go. Already mentioned by Stephen, this has been done in other parts of the world. He mentioned Egypt. There's a report there in the New England Journal about how that was done. Very informative to read about. It's underway in the UK. It's underway in the country of Georgia, not the state. And Australia has been underway with this now for 7 years. We had a really interesting conversation with the Australian leaders just a couple of days ago, and there's a lot we can learn from them as well. And it is working. So let nobody say we're just sort of out here in uncharted territories, just uncharted for the United States, except for these pilots. Other countries seem to think that it's doable before we got there. Now, what about cost? Because if you are in this town for more than 5 minutes, you recognize that what the Congress is really freaked out about right now is cost. And we're having this big debate about the debt ceiling and whether the budget needs to be cut in order to keep the deficit from growing. So let's look at that. After all, somebody who gets hepatitis C untreated and develops cirrhosis, develops liver failure, needs a transplant, gets liver cancer, is going to cost a lot of money. And that basically can all be prevented if we can identify those individuals and cure them now. There are a variety of reports that have been done in the past. I won't go through each of these, except to say that people have looked at this and it looks awfully compelling in terms of the amount of money that gets saved if you mount an elimination program. But here's the newest analysis. This is up as a preprint in NBER. I'll just show you the basic bottom line. This is Jag Chatwal, the Harvard economist working with colleagues at USC and Hopkins. And this is his prediction over 10 and over 20 years. Liver cancer, 20,000 cases would be averted in the first 10 years. Liver-related deaths, 24,000 cases averted in the first 10 years. And of course, it goes up fairly steeply over time because the long duration where this virus incubates in the liver before it actually results in these really frightening complications. And in terms of diabetes and kidney disease, that may surprise you that those are there. It's a recent, very compelling study done by the folks at Optum, where they followed 250,000 people, about 40,000 of which had hepatitis C positivity. And they looked to see what were the benefits over time in curing people. And somewhat, although experienced Hep C people were not surprised, I was not aware of this, they saved a lot of cases of diabetes and kidney disease from happening. This is a consequence of having that virus in your liver chronically, is what that does in terms of inflammatory responses that does damage to your pancreas and your kidneys. And those are expensive diseases too. So those are folded into this analysis, as you can see here. 50,000 cases of diabetes prevented in 10 years, about half that number of chronic kidney disease. So what about the money? Well, let's do the math. That's what economists are good at. Here's what you see. On the left is by subpopulation, where did the cost savings come from? But first, just look at the total. Over 10 years, $18.1 billion would be saved by a 5-year program starting today to find and cure people with hepatitis C. And that balloons to $57 billion in 20 years, again, because of the delay in onset of the illnesses that are so expensive. And you can see what the breakdown is there in terms of private, uninsured, justice involved, and Medicare. Over on the right, because this is what the federal government considers when they do a score for this kind of a program, how much money does the federal government save? In 10 years, $13.3 billion. We don't have a precise estimate on exactly what it will cost to do this 5-year program because it will involve this subscription approach to getting access to the drugs, which Rachael will talk about in a minute. And that's going to be a negotiation with the companies. But it will be well short, substantially short of $13 billion. So this program should be cost savings in the first 10 years. Now we await the Congressional Budget Office and its scoring system to see if they agree with this. They have seen these numbers. Will they agree with them is a big, huge question. If the CBO says that this program looks as if it's cost savings, it becomes vastly easier to get this through the congressional process. If they have a very different view, then it's going to be a much heavier lift. And so this is this sort of delicate moment while we are waiting to see what results might come forward with that. So with that, I'm going to turn this now over to Dr. Rachael Fleurence, my senior advisor, who has been a profoundly important architect of everything that has come to pass over the course of the last year that we've been working on this. And she'll tell you about the exact components of the program, and then we'll have a chance for some questions. Rachael.
Thank you so much, Francis. And yeah, it's really an honor to be here to talk to all of you about the plan and to get your feedback in the Q&A. So I'm going to go fairly rapidly through the three main components of the plan with you. The first component is about the point of care diagnostic test. So it was really shocking to learn that in the United States, we don't have a kind of same day test result option for people with hepatitis C, that actually it's 2, maybe 3 visits before people can initiate treatment. So one of the main priorities of our program has been to focus on diagnostic tests. Certainly we have a priority on the RNA point of care tests, which are currently available in Europe and Australia, but not in the United States. But we are also talking to manufacturers and laboratories about other sample type collections and also Hep B tests. The plan proposes to leverage a program called ITAP, the Independent Technology Assessment Program. This program was set up during COVID between the NIH's RADx program and the FDA that Tim Stenzel will be talking a little bit more about later. But it's able to accelerate both clearance and reimbursement for diagnostic tests. So we are hoping that we'll be able to really be able to accelerate the availability of point of care tests for hepatitis C and enable these test and treat, single test and treat programs that will enhance the cascade of care. As Francis mentioned, a second really important component of the program is this access to the direct acting antivirals. We have 3 components or 3 subcomponents to that. So first of all, a national subscription model. It's modeled, as Francis said, on the successful Louisiana program, the learnings from a state that need to be extrapolated now to the United States as a whole. The drugs would be paid for by the federal government and made available to Medicaid beneficiaries, justice-involved populations, individuals in opioid treatment programs, the uninsured, and American Indians and Alaska Natives receiving care through the IHS. Second subcomponent is for Medicare, where we're proposing some copay assistance. And the third is commercial insurance, where we'd be working with private insurance to increase coverage for hepatitis C testing and treatment and limit out-of-pocket costs. Testing and access to drugs are critical, but so also is empowering the implementation efforts on the ground. So we have a number of activities planned here to reach, test, and treat all affected individuals. And so some of the bullets here describe this. So expanding screening strategies and settings, especially for the high-risk populations, expanding the number of providers who can screen and treat for Hep C, expanding the number of community health workers and case managers who can link people to care. And we also have been talking with the whole vaccine community and think that re-energizing that part of the ecosystem is important as well, and maybe not so far out of reach as we may think. And then finally, some support as well for preventive services. So these are the 3 components of our program. Francis and I wrote a viewpoint. There's a little picture there on the right. You can read more about the description in there. And Francis mentioned a few points about where we're at in terms of our congressional strategy. We are proposing a mandatory program, so that's as opposed to discretionary. And that basically means that we're asking for sort of funding as a lump sum for the 5-year program. And so not asking every year, that depends on the congressional calendar, but really getting this lump sum approved. There are a number of advantages to doing it that way, and we can go into them. But we think that with the right amount of support, the Congressional Budget Office score, the right legislative language, this could be done even before October 1st, 2026. 3. But again, we do need this favorable CBO score. That's in the wings. We need the legislative language, and we also need lots of bipartisan co-sponsors in both houses, some of which we've already been able to interest in the plan, as Francis mentioned. Stakeholder outreach. I know Botima has a lot of questions for us after that we'll do in the Q&A about this, but we have spoken with many groups. We want to talk to more. So if any of you are particularly interested in this plan, like, please let me know, and so that we can get you involved in the discussions that we're having to get the feedback on the implementation. But really where we're at right now is this call to action that Francis mentioned. We have very strong partners within NASTAD, the AASLD, the American Association for the Study of Liver Diseases, the Association of Schools and Programs for Public Health, the NVHR, which is the National Virus Hepatitis Roundtable, and mainly these 4 groups that have come together as an informal group to really coordinate the outreach to Congress and work with the advocacy groups. They have a sign-on letter which has already more than 126 signatures. And we hope that we can count on your support today and in the next few months for this national elimination program. And as Botima said, the time is now for us to be able to do this in the US. So I'll leave you with this quote to ponder: "To know what has to be done, then do it, comprises the whole philosophy of practical life." So thank you for your attention.
Right. Can you hear me okay? Y'all are still quiet. We're coming to you next. All right. All right. Thank you very much to Dr. Collins and Dr. Fleurence. And let's jump right into it. Now, a lot of you might have already been familiar with the plan. You might have heard whispers about the plan, but it's real. It's a beautiful plan that a lot of blood, sweat, and tears and energy and advocacy and engagement has happened around in order to inform everything that you see in there. And a lot of what you see also might not have been in some of the initial plans. Through your engagement, we've actually really seen it evolve. But of course, you're here with NASTAD today, and our bread and butter, the loves of our heart, are health departments. And so the first question for you is, what is the anticipated role of health departments in the proposed initiative? The second part to that is, what opportunities exist to integrate the perspectives and expertise of the viral hepatitis and larger infectious disease workforce from health departments into the initiative and into its implementation? So we'll just start first with that first part, the anticipated role.
That's a great question, and glad to start into the Q&A here with you. And let me just say, while it's been a great privilege for Rachel and myself to be in this role of trying to organize the shaping of this initiative, it never would have happened without a huge amount of input from lots and lots of sources, including, I might say, all the folks who are here at this table who are our partners in HHS, in HRSA, in CDC, in FDA, in CMS. All of those folks had to come alongside and be willing to kind of take a risk, because a lot of people thought this might be just a bit more of a reach than we can achieve. And nobody ever said, no, let's just put this off. Once the case was made, we all locked arms and said, we have to do this. Hope the Congress will feel the same way. Health departments are going to be absolutely critical for us to succeed at this, the frontline opportunities that exist there. But at the same time, it won't be possible, I think, to do kind of a cookie cutter approach. Health departments are so different, and considering their circumstances, their environment, lots of different creative approaches are going to be necessary. And a lot of local involvement is going to make that work. I don't think this is a case where we can do a top-down management of this initiative and have it necessarily fit into the local environments that a lot of health departments live within. So that is going to require this kind of significant local knowledge capture and coordination. But Rachel, maybe you could say a bit more about this part of the plan.
Yeah, I'll just say a few more words. That currently our work is on developing the implementation plans with our colleagues, mainly seated at this table from SAMHSA, HRSA, the CDC, the FDA, as well as IHS. but we anticipate that a lot of the implementation will be done at the state and local levels. And in that sense, we do really need your input as the plans develop. So again, if any of you are interested in engaging more directly with our small team, then I'd love to hear from you after the session. One thing that maybe we briefly mentioned during the formal presentation are corrections. We really want to better understand the relationship between the state and local public health departments and the departments of corrections, and how we really could make progress and headway there, particularly if we are successful in developing the point of care tests. That could be a big breakthrough. So anyone with experience with the corrections departments in your state or local areas, that would be amazing to kind of hear from you. So yeah, I think I'll stop there, but just to say that we love and welcome your input as we continue to develop the implementation plans.
And I wanted to open that up to all of our panelists. So all of you work directly with health departments as well, and their partners, their community partners. So I'll give you a moment to respond.
Great, thank you very much. So really appreciate the opportunity to be part of this and at this time. Clearly, CDC has a longstanding history with their work with health departments, whether it be HIV, STI, or viral hepatitis. And in the program that we just saw, the points, the diagnostic innovations, treatment access through innovative models, and then comprehensive public health implementation, we definitely see that relationship that CDC has with health departments being a key pillar of the public health implementation aspect. So some of the ways, certainly not intended to be in total, but would be through technical assistance, through grants directly to improve patient-centered testing and ideally co-located treatment and prevention services, specifically in high-impact settings. Health departments and the community-based partners that you work with, either directly with funding or with CDC, have tremendous experience in this area and space. So we would want to leverage that. It could be accomplished through, I think, a combination of existing and new mechanisms. So for example, PS 21-2103, the Integrated Viral Hepatitis Surveillance and Prevention Grant, which is in its third year of funding, 3 of 5, would be in its fourth year of funding in fiscal year 24, should this get funded. It was built with elasticity, with exactly the opportunity to expand prevention and surveillance activities should additional funds become available. But there would also be needs for additional mechanisms as well. So I think similar to HIV and STD and prevention and surveillance activities, state and local health departments would play a pivotal role in the public health implementation. Thank you.
If I may add, from the health center perspective, I recently came across a wonderful story from Ohio. I don't know if anybody from Ohio is in the house, but I got a chance to talk to our Ohio Primary Care Association, who's worked really, really closely with the Ohio Department of Health. And they were able to receive some state level funding to deploy disease intervention specialists within health centers to support HCV prevention and providing care and treatment. And they started a pilot program back in 2018 and continued to blossom into a very, very strong partnership across all of the counties that had health centers there. And I think most recently, I was just sharing with Carolyn that they've been able to leverage CDC STI funding to specifically focus on hepatitis C. And so I think they're hoping to take the lessons learned from their hepatitis C work into other infectious disease domains. And I think that's just a great partnership that's been that we've been able to see at the state level, and then translating into the health centers at the local county level. And so we hope to continue to have that partnership. And from the health center perspective, we know how important state and local health departments are as our partners.
Thank you. And let me check and see. All right, so Dr. Fleurence, I'll pose this one to you, going back to the stakeholder engagement. The theme around this entire meeting is recentering key populations. And actually, as we we're really challenged with this morning in a good way, in a wonderful way, in a needed way, was that for our most marginalized populations, particularly populations who are disparately impacted by conditions like hepatitis C, we're really at a point of centering for the first time. And with that, I wanted to ask the question of what action you've taken in your engagement to specifically incorporate the expertise of people with lived experience and populations that are disparately impacted by viral hepatitis.
So we've been working on the plan for 15 months. I think we started in April of last year. We've engaged with several important organizations, including, and I especially want to thank them, the National Viral Hepatitis Roundtable, who've been extremely helpful in providing us with input and advice along the way. They have a number of members who do have lived experience with hepatitis C, and including Dr. Alicia Suarez, who's a professor at DePauw University, but also a person who was cured of hepatitis C, actually with the interferon, so not with the DAAs, but with the interferon. But she's been a very vocal and persuasive advocate who's provided us also with some input on the plan. I will say that we're not able to formally mount committees because there's lots of federal rules around that. So we're dependent on groups of voluntary people kind of coming together and providing us with the input, but we'd like to continue certainly doing this over the next year. So again, if you have ideas, recommendations for me about reaching out to specific folks, I'd love to hear from you. I will mention we did have a couple of large meetings that were led by Lauren Sand and Ronnie Marks, who are advocates in the hepatitis C space, that provided us with some actual formal feedback on some of our earlier ideas back in December. So I guess the answer is we've definitely made efforts for outreach and people have come out to kind of help us, but we'd like to do more if possible.
Awesome. So I'm happy to shout out a number of NASTAD's board members who have themselves been engaged in work on viral hepatitis elimination, and who have stakeholder groups who are working with people with lived experience. And so I think there's a neat opportunity for NASTAD to really work with you all to engage those individuals, especially given the leadership that they've had over the elimination work that's happening in those jurisdictions.
That would be great. Please do.
All right, also a theme of this meeting and a significant part of the work that I'm doing and working with the directors at NASTAD, as well as the senior directors and leadership, is around syndemic approaches. And rather than being so formal with it, I think that we're getting to a point, especially as we talk about status neutral approaches and integrated approaches and braided funding and all of these different ways of just getting down to when people are coming to us and they have needs, go to one person or another person. I want us to be in a point where we are so unified that we can say to that person, you tell me what your priorities are, and I know the team that I need to bring together in order to address them. And so with that being said, there's all these conversations, including by our federal panel yesterday, around the fact that that's the point we want to get to. We want to use syndemic approaches. We want to get to a point where we're not taking a siloed approach to the work. So then the question there is, we're talking, and I know there are folks out there who are saying, I'm hearing C, I didn't hear A or B. We'll get there. But before we get there, just thinking in terms of how we can integrate this work into the existing HIV infrastructure, the existing STI infrastructures. How does some syndemic approaches play a role in how this program will be implemented in review?
It's a great question. I think it is on a lot of people's minds. It's the balance between wanting to take every possible opportunity with an initiative of this sort to also touch those syndemic needs that you've just outlined and make sure that we could actually build capabilities even beyond hepatitis C, but not packaging the initiative so that it seems so broad that the Congress doesn't wrap their arms around this as this unique historic moment, because we can cure hepatitis C. That is a big part of the message we're trying to put forward. And if we don't, people are going to die needlessly. I think, though, when you consider the way in which this would play out, and you saw the way in which the plan was put forward a bit ago by Dr. Fleurence, we will certainly end up increasing the amount of hepatitis B testing because that is part of the protocol for finding out whether somebody is Hep C positive and needs to be cured. And so that's going to be folded in there. In fact, we are really interested in trying to come up with accelerated ways to do the hepatitis B testing as well as point of care, motivated by this very thing. We want to be at the point where you can do test and treat in one visit. And ideally, that would mean being able to do Hep B and Hep C, not Hep C antibody, but Hep C RNA, and then hand the person the pills in that same visit. That's the gold standard we aim to get to, and I think we could. But on top of that, of course, a lot of the same clinics where this kind of opportunity will be offered, and where we believe if this program is approved, we'll have additional resources to make it so, should enable HIV testing, should enable HIV. Have an overlap of substantial sort with substance use disorders. And I'm glad my colleague from SAMHSA is here as well and may want to talk about that, because we know that is a golden opportunity for the ability to do testing and curing for Hep C, where the incidence and prevalence is unfortunately high. And those kinds of resources also ought to be synergistic. So I can't tell you in every situation exactly how that will play, but this really ought to lift the opportunities in all of these spaces if we do it right.
Thank you, Dr. Collins, and thank all of you for the work that you do. And I do want to first state that SAMHSA doesn't believe that there's a wrong door when it comes to accessing this care. While our goal is certainly to promote mental health, prevent substance misuse, and provide services for substance use disorder treatment, as well as recovery services, we also understand that hepatitis C did not occur in a vacuum. These grantees and enrollees to these grant programs are dealing with a myriad of issues. Wraparound services are critical, but also the idea that not only is there no wrong door, but the workforce needs to have the resources available to it to actually address all of the issues as they come through the door. Certainly, SAMHSA grantees are able to provide HIV testing, hepatitis C testing, hepatitis A and B vaccinations. The idea that we're going to try to take a whole person approach is where we would like to see everyone land. And I think the idea that we have synergy with our federal partners, braided funding being a great example of where this can occur, but also partnerships, strategic partnerships with our state partners and state health departments are going to be key. Quite frankly, you know, a lot of these applicants to our grantee programs are not always well heeled. They need these partnerships. They need to utilize what we can give them in terms of flexibilities, the certain flexibilities that we now have with telemedicine. Certainly, we're looking to expand that to make sure that as testing occurs, that the appropriate referrals are made. In addition to that, we expect that whatever we have done and learned during the pandemic, we continue. And we expect that not only will this partnership move forward, but we're going to be informed by what you tell us. We've held listening sessions to ensure that we're headed in the right direction, and you'll tell us when we're not. The idea that we've stood up our Office of Recovery so that individuals with lived experience can inform our policies is really the bedrock of where all of us stand. And we hope to continue that work. So thank you.
As a quick follow-up to that, Dr. Gandotra, one of the issues that we know some of our viral hepatitis programs run into the challenge of is behavioral health is often receives SAMHSA funding, and they don't necessarily always have the working relationship with their behavioral health counterparts. So while they know there's this unique opportunity for funding to support viral hepatitis services, they don't quite know how to have that conversation with their colleagues, or they're not necessarily in a position to connect with those colleagues. Are there any recommendations that you would have for how to make those connections?
Well, thank you for the question. I'll say, first of all, as part of SAMHSA's interim strategic plan is for further integration of behavioral health and physical health care bi-directionally. And we offer a number of resources in the form of technical assistance in each of the 10 regions within HHS for healthcare integration, as well as behavioral health management and testing for STIs, infectious diseases across the board, HIV, as well as viral hepatitis. So that would be the first place, is our technology transfer centers. And then, of course, take a look at our web pages, and we have an evidence-based resource center for healthcare administrators and clinic administrators on how to implement some of these integrated policies. And if worse comes to worse, you can always call me.
Remember you said that. All right, this next question, not to put you on the spot, but Dr. Wester, you have led through the Division of Viral Hepatitis a significant effort to take us to a limited number of jurisdictions that were receiving viral hepatitis specific surveillance funding to now having 58 funded jurisdictions across the country. But we're still in this challenging place where, if my numbers are right, hepatitis surveillance and prevention funding is at about 23 million, while we see our HIV counterparts, and this is not challenging that more money is needed for HIV as well, but our HIV counterparts are funded at about 400 million for prevention and surveillance. And so thinking about how we gear up to get to a place of implementation, what is the plan to track testing and treatment outcomes under the proposed initiative? And what role will viral hepatitis surveillance programs play? Also taking into consideration, what are some of the things that we might be able to do now to get us to a good place to implement when the time comes?
Well, thank you. I'll give you thoughts and perhaps not a definitive path. But I do want to echo and actually say that the funding that goes for prevention and surveillance is actually about 18 million, because 21-2103, you're right, is 23 million, but that includes the special projects for people who inject drugs. So we've got about 18 million going across 59 health jurisdictions, about 200,000 per jurisdiction specifically for surveillance. So obviously some jurisdictions have been doing this longer than others. Others are just getting started and doing that heavy lifting across 7 conditions. I'm just talking about A, B, and C. That's acute, new, chronic, perinatal, with hundreds of thousands of reported cases across those 7 conditions each year. So that's enough for about 1 to 2 FTEs. So your question is very fair. So thank you for asking. I want to put it in between kind of outcome targets and also program targets. So outcome measures, when we're thinking of viral hepatitis elimination, often, at least if we follow the WHO model and also our HHS plan, are for acute or incident cases as well as related mortality. So we're using currently surveillance data and also vital statistics data for both of those outcome measures. And additional surveillance funding will allow us to have additional case detection, case investigation, outbreak detection and response, public health laboratory capacity, et cetera. But for those other measures, which are some of more of the program, and I will say you've also rightly resourced, and a lot of jurisdictions are moving towards this already, the longitudinal registries for Hep C, which include both detectable and undetectable RNAs, that will allow them to assess their clearance cascade, at least starting with diagnosed and following through viral clearance as well as subsequent infection. So while that capacity is being built for those outcome measures and cascades with surveillance data and viral statistics data, there are also other data sources that we can use for some of the program targets. So for example, IQVIA data for pharmaceutical claims. We can look at number of prescriptions that are written. We can also use commercial laboratory data and other data sources to look at number of tests conducted. So there are other opportunities for us to use, not only to monitor those testing and treatment kind of targets or achievements, and we can do that not only on a national level, but there's potential to do subcategorizations using those data sources too, geographically and also subpopulations. And the last thing I'll say is that even with our current funding, our EPI and surveillance branch is looking at alternative data sources for looking at things like prevalence, et cetera. So with additional resources, we'll be able to dig in even more. Over.
And in that, that was also a beautiful connection to syndemic approaches in that you named labs. So working with our lab folks, which we know a lot of our viral hepatitis folks are already doing, engaging infectious disease surveillance for folks who are working in other areas, vital statistics. So thinking about it in that way, we're not just thinking about just 1 to 2 FTE scaling up into something huge, but that there are a number of partners to bring to the table in order to do the work. All right. All right, we have time for, I think, just a couple more questions before we'll transition to our folks who are online. So if you are online, we're going to turn the camera on you. No, I'm team. We're not going to turn the camera on you, but we'll give you an opportunity to ask your questions, as well as to everyone in the room as well. But before we do that, one of the questions I want to make sure to talk about is with Dr. Stencil, who's joining us virtually. So Dr. Stencil, as you know, as you're very well aware, the proposed initiative specifically highlights rapid acceleration of FDA approval for point of care HCV RNA tests, which we've heard Dr. Collins and Dr. Fleurence discuss earlier. Are there efforts currently underway at FDA to facilitate accelerated approval of a rapid hepatitis C RNA test to provide same-day results and support same-day treatment initiation? And if not, can you address some of the barriers that may have prevented approval to date?
Thank you. Hopefully you can hear me okay. It's great to be here. The FDA has welcomed submissions in this area. We took efforts to down-classify HCV from class 3 to class 2, making the submission a 510K. So it's the easiest submissions to be done. We are working closely with NIH ITAP, as been mentioned, and we are working with a lead test developer to offer hopefully an HCV molecular result, identifying patients with active HCV that can be done with a single visit with a single test. With sufficient funding, NIH will need some funding for this to get it over the finish line. We anticipate the authorization can happen surely within 2024, if not before. The FDA has formed a team inside to streamline our review feedback, as we have done for the recent emergencies, COVID and Mpox. This has led to the ability to authorize products through the ITAP process once we receive the final data set. For EUAs, at least, it might be a little bit longer for 510Ks, within hours of the receipt of the final data set. So the alignment between NIH and the FDA has been really great. There is a challenge for the easiest to use point of care testing, and that is a finger stick sample is probably the ideal sample type for this type of test. However, those types of samples can't be banked or stored and tested later versus, say, a venipuncture sample. So, in order to be successful in the shortest possible time, we'll need to identify multiple high incident clinic sites, multiple because that will shorten the study time, and high incident because it can reduce the number of patients that need to be enrolled. We're also eager to work with HBV assay developers to provide a point of care active HBV test. We have already engaged with 2 developers. This is currently a class 3 device, so it's a PMA, but there are mechanisms to down classify it, and we are looking into that. Thank you.
Wonderful. Thank you so much. And I appreciate you also integrating into your breakdown of what's happening at FDA, that the work is not just happening on hepatitis C diagnostics, but also actively happening on hepatitis B diagnostics as well. All right, for our last question, before we open it up to the floor, so many, gotta pick. Let's talk 340B. Dr. Lynn, this question is for you. I'm just going to jump right to it. What is the potential impact? Because we know it's on the mind of our providers for sure. We know a lot of our programs who are in the room, partners of the programs that are in the room, are able to use their 340B rebates in order to develop significant programs, everything from peer navigation, similar to the DIS programs that you described, to viral hepatitis testing programs, innovative syndemic programs. So with that being said, what is the potential impact of the proposed initiative, particularly the federal drug procurement program, proposed federal drug procurement program, on programs that rely on 340B revenue to sustain their viral hepatitis clinical and other services? And have you considered ways to prevent any anticipated adverse effects?
Wow, that is such a hard question. And I think many of you have heard about the 340B, and I know I just had a chance to meet the health policy folks, Emily, here at NASTAD. It is an incredibly, incredibly challenging situation. I think our health centers have done a great job using 340B savings to support linkage to care, to develop further develop our primary care teams to include clinical pharmacists, community health workers, to support HCV patients at health centers. And so I will say there is no, I don't have any sort of magical answers to solve the 340B question. I will say on the health policy front, one of the stakeholder groups that Dr. Collins and Dr. Fleurence had engaged is the National Association for Community Health Centers. They are currently, they have a survey out with our health center CEOs or their designee to get the perspectives on the ground of the CEOs to see how that can inform the health policy agenda for NAC. In the next couple of months. They've also formed an alliance to Save America's 340B program, which is a partnership of community health centers, patient provider, consumer advocates, to similarly, bring a health policy agenda together to bring the issues of 340B to the forefront. I will say that, in our December conversations with Dr. Collins and Dr. Fleurence, I had said that, if the primary care safety net is going to advance this work, additional resources, new resources are needed in this space. There are a couple other things, financial factors that the health center program is confronting at the moment. The health center program is up for reauthorization in August. And then also we are coming to the end of the American Rescue Act plan funding that had infused resources to support health centers in their community COVID response on the ground. And so with that, and then also Medicaid redetermination, and I don't know how you all have talked about that particular issue here, but there are many, many factors, financial factors that the health centers is confronting at the moment. So it's a very tough situation. And on top of that, there's also a healthcare workforce burnout that we're dealing with as well. So I think forging ahead, it will take all of us to bring forward a health policy agenda forward, and then also to look to the possibility of additional resources to advance this critically important work. So, but no easy solutions on the table, but just also putting out there some of the financial challenges that we're confronting as a health center program.
Yeah, that's a very nice summary. And I think we are very aware that this should not end up being a negative for those health centers that are currently very much dependent upon 340B. There's a couple things that will help. One is to put resources into this initiative to assist with that. Another, of course, is recognize now those health centers won't have to pay for the drugs. So there will be some benefits there of funds that otherwise would have gone into drug procurement, which could now be utilized to take up some of the slack of what 340B has been providing, although it won't be a perfect match. So I think there's a lot of sensitivity to the issue. And certainly if this program is going to succeed, those community health centers are going to be a critical part of the solution. So we want them to be able to wrap their arms around this with enthusiasm and not feel like something got done to them that made life harder.
And Dr. Collins, we appreciate that so much. And I think there is health centers do want to support and advance this work ahead alongside of all of you. And I will say that during COVID, I had the unique opportunity to set up a HRSA channel to distribute vaccines, point of care tests, and antiviral therapeutics. And so we know test to treat is possible within health centers. We've distributed over 4 million point of care tests and then over 140 courses of antiviral therapeutics. So I think health centers have built up the infrastructure and the capacity to do this and are excited to be engaged.
All right, with that, I will ask our folks in the room to line up if you have questions. We have mics on both sides of the room and we're happy to take your questions. I see Andrew ready to go. So we'll hand it off to you. And while Andrew's speaking, we'll look forward to other folks who have questions as well.
Thank you. Andrew Gans from New Mexico. And okay, first of all, incredible excitement that we have national leadership on an elimination plan and, 10 years into DAAs, this is the time. So I wanted to come back, we are the Association of the State, Local, and Territorial Health Departments, and our meeting is recentering key populations. So wanted to highlight where that overlaps, and I think you've all mentioned some of it. One is really coming back to surveillance and epidemiology, and Dr. Wester made some really good points I was thinking a lot about. But if we really want to start a new initiative in a way that recenters key populations and looks at disparities and achieving equity, if we don't have surveillance in the mix, we can't get that done. And I don't know how much in this initiative is going to go to support the very small but important amount of money that is in DVH to do the surveillance work, because now everybody's funded, but at a low level. I really want to do something like a longitudinal registry in my jurisdiction because we're trying to eliminate Hep C in New Mexico by 2030. How are we measuring that? Right? We're so lab dependent. We're not looking at treatment data. We're not looking at prescriptions, et cetera. So certainly surveillance, epi, working towards equity and around disparities. And the other side of that is harm reduction. And I think we need to emphasize harm reduction all we do. And the expectation is we're just talking about infection and reinfection. But actually, our harm reduction, of course, it's the best in the country, but not just because we have 4,000 unduplicated clients to avoid infection and reinfection, but those folks come to us routinely. They trust us very often more than other healthcare systems because they've had really negative experiences as people use substances in other systems. They're not going to walk in primary care, even if it's free, even if it can cure this disease, even if it can avoid cirrhosis and liver cancer, because they don't want to be treated like crap when they walk in the door, but we can do that navigation. So I think, places that don't have certain services and other harm reduction models are at a disadvantage working towards elimination because the populations that we need to recenter, the people, the cisgender white men my age who have Hep C, they've all pushed their way into primary care and been cured already. Right? That's not what the population we really need to reach if we're going to do elimination looks like, and they need our help. And so that recenters health departments, it recenters surveillance work. I want to do everything that Dr. Wester mentions. And I think it can be hard to sell a new funding initiative right now in Congress if you talk too much about harm reduction, but I think talking about it's a great model for building trust to navigate these populations. It has to be said at some point. That is really significant. The last thing I'll say is subscription model is very exciting to some people, not so much in our jurisdiction. We are using 340B discount through our STD program to do elimination in our state prison system. And with the estimate that saved us about $15 million, our legislature funded with state general funds the entire rest of the estimated cost for a 4-year elimination program. So different models in different places. Subscription I know is exciting in some places, but 340B discount, even without, obviously we're not rebate or revenue in corrections, that savings was very appealing to our leadership and they funded us. So different models in different places, but as long as everyone's trying something, it is moving us forward. So thank you.
Thank you so much, Andrew. And thank you for sharing the awesome work that's happening in New Mexico. Because I think something that you also highlighted too is there's a lot of pressure on this initiative, right? There, especially knowing that we are relying on Congress to make the right decision as far as this plan will go. But then there's also the piece about what can already happen. So just like what you described in New Mexico about being able to utilize state general funds in order to launch a drug treatment program, a hepatitis C treatment program within corrections. We also are hearing from California. I'll shout you out as well, that you went to your legislature and you fought in order to receive funds that will allow you to do work across HIV, viral hepatitis, and STIs, as well as use it to support and complement your harm reduction work. So it's not just a matter of how do we get this plan funded? That is absolutely a critical matter. I want to be clear about that, but also thinking about what opportunities lie in front of us right now, absolutely right now. So I'll turn over to my panelists and see if you have any responses to Andrew's comments before we turn over to other questions.
Carolyn already talked about the CDC surveillance efforts, and they do a lot with that $18 million. But obviously, if this is going to be a national program, we're going to need a dashboard so that the Congress can be informed, and they will expect to be, whether it's working or not. And so there's going to need to be resources that go into that. Again, if there's a subscription model and you have the ability to track, therefore, where are the cures going to and count them, that's another source of data that should be pretty useful to see how the program is proceeding. But there are resources planned as part of this initiative to try to beef up the surveillance. We don't expect the current system to be adequate in its own current state.
So thank you so much. Yes, echo that. We 100% recognize that this is a kind of a floor setting and need to build across it. And we have that elasticity to move forward should the additional funds become available right away. So delighted for that. In the current context too, as you know, we're moving more and more, not as quickly as we want to, but as funds are available into federal support for harm reduction program. NASTAD has been a wonderful partner. This is going on also through the HIV prevention funding opportunity, but through the viral hepatitis prevention funding opportunity, and now through the funding opportunity to NASTAD directly to syringe service programs. And those are coming through line items outside of viral hepatitis, including infectious disease consequences of the opioid epidemic. I know HIV funds are going into it, and we believe there's other opportunities too. I mean, in terms of the context of substance use disorder prevention. So we'll continue to leverage those, and should that be a big or small or no piece of this, we'll continue to look for other places, because we recognize that prevention and treatment is what's going to eliminate in our younger adults. And then the 340B. So I want to compliment you all. You have done a tremendous job, and there are some other exceptional examples throughout this room, whether it's correctional facilities or primary care or other safety net settings. But I will say it's a patchwork. And when we look at the data, you know, if we just look at the 9 jurisdictions with the prevalence data that we have, for better or worse, that account for over 50% of the prevalent cases, some of those very large systems haven't even begun to look at it. And so I think a national program gives us the opportunity. And although the 340B, even in those forward-thinking, you know, states like yours, It will still provide it would, as described, provide that 340B savings, which could then perhaps be invested in other areas. But I think, as was mentioned and discussed, it's like, okay, well, then let's just make sure that the 340B savings in the healthcare settings are supported through other means. So,
All right, so with that, we are at time, but before we wrap up, before you jump up, because I know we all need snacks before we go into the breakouts, I just want to say one piece. I know there are a number of folks who are in the room who have been working maybe in your area for a long time. You've been trying to figure out what to do with your hepatitis program. Maybe you're new to the program, maybe you're new to overseeing your hepatitis program, or you just want to better support your hepatitis staff. What I would urge you to do is to take the plan that you've seen today, take it internally, and have discussions with your team about how you might implement at least components of what you see in that plan now with the resources that you currently have now. I know your viral hepatitis resources are limited. That's why I'm not necessarily only talking about your viral hepatitis resources. But that is a charge that I'm going to leave you with and sincerely ask you to take it to heart. Take your plan, take the plan, look at its components, and realistically approach the fact that you could do this, that we can do this work now as we wait for the plan to officially get funded and we eliminate viral hepatitis nationally. With that, I want to thank our panelists and thank all of you for your participation in today's session.